Are you able to see my screen and hear me well? So thank you very much.
Perfect. Thank you.
So the objective here is to bring another perspective on CNS anomalies, bring cases from low and middle income countries. And as you know, I'm here in Brazil. This is my country. This is São Paulo state. Here you can see São Paulo, the biggest city in Brazil. And here we are in Ribeirão Preto, a city in the northeast region of São Paulo state. You can see here my city, my hospital, Hospital das Clínicas, and the Faculty of Medicine of Ribeirão Preto. And let's try to bring a couple of interesting cases here. So this first patient is Miss A, a lady with 27 years old, on her second pregnancy with a previous C-section because of pelvic presentation. She doesn't refer any use of smoking, alcohol, or drugs. Increased BMI, 36. The patient, in fact, was referred to our specialized clinic, not because of her chronic hypertension. This was followed in the primary sector. Before pregnancy, she used these medications here, but now during this pregnancy, enalapril was changed to alpha-methyl-dopa, and she also used aspirin and calcium for preeclampsia prevention and was using vitamins, ferrous sulfate. And the reason why she was referred to our clinic, it was because subsequent urinary tract infections. In fact, she was treated 5 times during this pregnancy because of urinary tract infections. She arrives at our specialized clinic at 32 weeks, and she brings 4 previous ultrasounds. You can appreciate here the gestational ages. The estimated fetal weight was okay for all these scans, the second and third trimester scans. Amniotic fluid looked fine. Placenta was anterior high. Low risk for aneuploiditis in the first trimester screening. Unfortunately, no images attached to the ultrasound report. So this is how the patient arrives at our clinic. And well, we usually, when the patient arrives, we because of her chronic hypertensive condition, we wanted to see the baby if the health was okay. And these are the first images of the biometry of this baby. And when the patient arrives at our service, the first person that start dealing with the biometry and with the ultrasound, they are not our trainees. They're second or third year residents. And I would like to ask you if you see something unusual in these pictures here. Can you see, Asma? I cannot see the chat, but please, if anyone says something, please let me know here.
Let's give them just a few seconds. So just to encourage everyone, someone said the shape is not okay, abnormal profile.
Yeah, and I would say that we probably see a cerebellum here, so probably it is not the best plan to do the DBP and the CC. Well, we are in a CNS anomalies course, so let's focus on these 2 first images.
Many comments, by the way. So this frontal bossing, wrong BBD. They don't like they don't agree with the measurement. And they think this baby's micro brachycephaly and Kelsey saying brachycephaly and intracranial asymmetry. Cerebral. I mean, okay, there are many comments. You've got a lot of engagement here.
But let's say, well, at least the image was not really informative here. So, but the first thing when our consultant entered the room and started to checking the images, the first thing that was striking was that CC was above the 9th centile. So the cranial measurements were a little bit increased. And well, you can see that the ultrasound is not really good. The patient had a high BMI, as we previously talked about. You can see here that maybe the midline is a little bit shift. they started to get a little bit worried about the width of the lateral ventricle. And here, when you obtain a better image, you can see that, yes, indeed, it seems that there is a midline shift and that the posterior horn of the lateral ventricle is a little bit enlarged. And they decided at this point to take this patient from one room to another room to have some views with a better ultrasound, a better equipment. And here you can see it's in the same day. They just changed the equipment, and now you can see here that, well, a lot of things. Thalamus, you can see one side of the thalamus, not the other one. You can see this structure here that seemed to be inside the lateral ventricle, and indeed the lateral ventricle was indeed enlarged, what was not really apparent in the other side, in the other aspect of the cranium. You can see here these cystic images that were more related to this anterior part of the left hemisphere. MCA was quite okay. And the conclusion for this screening scan, a really unexpected finding, as you can see, was that there was microcephaly, a left lateral intraventricular image, and they were suspicious about infection and about clot, or maybe an ischemic insult leading to bleeding. And this was their first impression. But they, of course, referred this patient for a more detailed exam. Unfortunately, as you can see here, this patient was still in the third trimester, almost 33 weeks of gestational age, and then we could see this patient a little bit better. And the first images looked really similar to what was previously found. We can see a strikingly enlarged left posterior horn of the lateral ventricle. This echogenic mass or structure inside or with close relation with the lateral horn. Amniotic fluid at this point was a little bit increased above the 90th centile. You can see the midline shift as well here. And in fact, there was microcrania, as you can see here. And here we tried to identify this solid structure here, and the parenchyma in the anterior aspect of this left hemisphere was completely abnormal, as we've shown in previous images. The left thalamus was really difficult to insonate, and the contralateral horn of the posterior ventricle was fine, but only you can see here that the Willis polygon was really fine just below those structures on the thalamic plane, but only after turning the Doppler on, we could see that there was Doppler signals inside or around and inside these structures. So this probably wasn't a clot, and indeed it was a solid tumor, and it had arterial flow inside, as you can see here. So our conclusion at this point was that there was indeed macrocephaly, polyhydramnios, a left lateral intracranial tumor, probably coming from the area here of the thalami, with a midline shift. And this patient was referred for MRI. And these are the images, the longitudinal images here from this baby, and you can see strikingly. So this was 2 weeks later, and we can see this striking midline shift and this solid cystic aspect of a brain tumor inside the left hemisphere, and with marked dilated ventricles here, lateral ventricles here. The report from our radiologists was of probable high-grade, predominantly solid neoplastic lesion in the left thalamus, compressing the aqueduct and third ventricle with marked lateral ventricle dilation, more to the left than to the right aspect of the brain. And here you can see also axial images from this MRI showing the same things. And here you can see that this is really similar to what we were seeing on ultrasound during the third trimester, something that was not spotted in 4 previous ultrasounds, including one with 30 weeks and a few days. So really important to screen and to look inside the brain at every opportunity during antenatal care. So we took this patient for a multidisciplinary team meeting where it was informed to the patient that probably we were having, in this case, a intracranial neoplasm. The most probable etiology would be an teratoma, talking about what is more common. But, well, of course, the postnatal diagnostic confirmation would be required. If we were correct, unfortunately, the prognosis is not good, with more than 90% of mortality. So the family was consulted about all of that. And the plan was to do a planned C-section at 37 weeks due to the macrocrania that was already very clear. Unfortunately, this patient did not arrive at 37 weeks. At 36 plus 2, she had a PROM. She started having contractions, and we opted for C-section because of macrocrania, and she had a tubal ligation. This was previously agreed. And the baby was 3.1 kilos, 49 centimeters in length, apgar 9 and 10. Head circumference was more than 40 centimeters, 42 plus 5 after delivery. And the mother was fine and discharged at the second day after C-section. What happened to the baby? Well, the baby was really well after delivery. No complications, breathed well, started to breastfeed. But here we can see first images from the transfontanel ultrasound, and here we can see striking midline shift, that cystic appearance, and the solid mass close to the thalamus, and the conclusion was of an expansive solid cystic lesion, probably teratoma or a papilloma or a choroid plexus carcinoma. These were the suggestions from the radiology team. And later on, she had an MRI. Unfortunately, I was not able to obtain the images from this MRI because our PAC system had some problems, and this week I could not get these images. But the conclusion from the radiologists that assessed the MRI was that it was a congenital high-grade thalamic neoplasm, likely a midline diffuse glioma, and this was the first time that this word appeared here in our case. On day 4, the baby was submitted to a ventriculoperitoneal shunt placement, and on day 9 of life, there was a subtotal tumor resection by neurosurgery. The pathology reported a high-grade glioma concordant with what was seen in the MRI, the postnatal MRI, with these immunohistochemic characteristics here. So we are going to talk a little bit more about this in the next slide. And the current proposed treatment was chemotherapy, apart from the surgery, 6 to 8 cycles of these chemotherapeutic agents here as proposed by our oncology team. And to finalize this, a last slide for this case. So with respect to fetal gliomas, they are very clinically significant, but they are rare. They represent less than 2% of congenital brain tumors. But gliomas are among the most common subtypes of these brain tumors. The clues in ultrasound and MRI are solid cystic lesions, often in the midline, with macrocrania and ventriculomegaly, and we were able to see this in all ultrasound and MRIs after the patient arrived at our service. Unfortunately, related with poor prognosis, especially if midline high grade and H3K27M mutant, and this was the case as we've shown in the last two slides. So baby is being treated, and considerations for antenatal counseling. So unfortunately, this is often lethal and severely debilitating, and the prenatal diagnosis allows for delivery planning. So we knew about them microcephaly, about the probable diagnosis. So it's important for parental counseling and possible early intervention, and this baby was treated in the first week, first 9 days of life. So Asma, this is last slide from this case. I would like to know if you want to comment or discuss something.
Yeah, I think that's a very interesting and a really excellent case, and also sort of from real life. Is that what's what happened in real life? You get a referral, you don't have previous scans, that also obviously it depends on how big is the patient, how difficult the scan her, and also showing stuff how you can maybe improve the quality of the scans, how the finding is affected the next steps in terms of the investigation and management. So a really fantastic case. Thank you very much for sharing it with us. There were some questions, there were lots of comments, really have a lot of engagement here. I cannot trying too hard to focus with you and follow the comments and the questions. So Ghassan al-Shammari asking, was it intraventricular?
Oh, in fact, it was it came from the thalamus, so it obstructed the ventricle, but probably by compressing it. But the first images, the first ultrasound impressions that we had is that it was inside the ventricle, but I think on the other hand, it invaded the ventricle afterwards, probably coming from the thalamus.
Okay, fantastic. What's the earliest gestation that gliomas can be diagnosed antenatally?
Well, I think it depends on when it appears, but well, probably from the second trimester on, I would say.
Yeah. So, I mean, I think these cases are really rare. I think the earliest I've seen of brain tumor was actually in the first trimester. But they're very, very rare. I think even the sacrococcygeal teratoma, I think, again, mostly like present in the second trimester or later. And I've seen in my career only 2 cases that actually were diagnosed in the first trimester. And again, that's consistent with the literature. Okay, so as a general obstetrician, if I was to scan 3 structures to screen for fetal, which are okay, so this is actually some general questions, not just about this case. Okay, so I think there will be another discussion, and I also invite Francesco to join us, but you have more cases?